Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD podcast. Tro, we're reunited again.
Look, I'm so excited actually about this because we're going to talk about topics that are near and dear to me today. And I'm so excited about the guest, somebody I've known for a couple of years now and talked with and interacted with. This is going to be extra special. Mental health is one of the most important topics facing our whole country right now. And I think for the longest time, we've sort of poo-pooed it. We haven't really given it the respect it deserves. And in fact, Brian, when 7 years ago you said, maybe food has something to do with our mental health, people on the internet said you should lose your license. And I wonder how those people feel now.
But they're not going to listen. They don't want to know.
Yeah, they don't want to know. But I'm excited, okay, because we have Katherine Tague, who is here with us. She did her undergraduate at Boston. She did her master's in mental health at Fordham. She is trained, done the training with Dr. Georgia Ede and worked with people like Nicole Laurent. And she has been exclusively in the eating disorder and mental health space for the past almost 2 years. And I am just absolutely excited to hear everything she has to say. I'm so happy that you came and joined us. And you're going to be joining us I think next week as well. So happy to have you.
Yeah. Thank you both.
Can I start with a story?
Yeah.
Okay. Brian, I know you're going to have
You
to
said you weren't going to talk a lot and you're going to start with a story.
I know, I'm going to start with a story. Okay.
All right.
I got a call from a world-renowned psychiatrist. And he said to me, Tro, we have to do something. And I'm like, what do you mean? He's like, I've left my career. I can't practice this way. In the field of anorexia and eating disorders, they have decided that it's appropriate to use compassionate euthanasia. They said that in places like Canada and the UK, they are now arguing, the academics are arguing that instead of making these patients suffer, that they are arguing that we should allow them to commit suicide. And in fact, doctors now have formally helped patients with depression and anorexia commit suicide. And my heart sank. My heart sank. And this doctor felt so strongly that we are not treating people with eating disorders appropriately. We are not giving them the care they need, and we're certainly not giving them the nutrition they need for their brains to function, right? And so let's start maybe with the hardest topic. Let's start with that.
Yeah, I mean, the thing about, when I really stopped, like anorexia specifically, first of all, like it's interesting that as a treatment community, we lump these conditions together because they relate to food, body, and eating, understandably so. But anorexia specifically, like it's a confounding condition. It's not biologically consistent. It's not evolutionarily consistent. There are some theories about this, right? Animal studies or evolutionary studies. The less food you have, the faster you will run. You need to find your food, but it's really not evolutionarily consistent that you would. Why would a human being do that? Why would someone starve themselves? And so it is confounding in that way. It's not consistent with thriving, and the medical suicide, the voluntary euthanasia. It's when that piece came out. I have a colleague who. She's she's a lifelong New Yorker. I think she probably reads everything that comes out in the New York Times every day. And she sort of is one of these people who she's the first to, like, when something comes across her desk by 9 o'clock or whatever, she'll just forward it on to a bunch of colleagues and clinicians. And she takes the time to read through all this stuff, especially if it's editorial in nature. And I knew there were people on this thread who they didn't know that I have this metabolic health interest, or, that I had sort of been like keeping my interest away from this group of clinicians. And I remember responding immediately and saying, like, there is so little we understand about mechanisms. There is so little we understand about how to appropriately support these people. And just frustrated and sad.
Well, before we go into that a little bit further, maybe tell the viewer a little bit about yourself, how you got interested in sort of mental health, how you got interested in metabolic health, and how you came to the point where you're even commenting on anorexia and the interplay between eating disorders and mental health.
I always feel compelled to say that there are there are certainly more qualified people than me. There are certainly brighter, more researched people than me, but I just have I'm sort of like dissatisfied with things as they stand, and I can't let it go a little bit. So that's sort of my truth. But I decide in a prior life, I worked in news. After 2020, I decided I had to do something really different. I wanted to work closer with people. I went back to school for counseling. It ended up being a good decision for me. And just being a young woman, I basically felt like, what do I know other than being a young woman? I'd been a dancer, so you're spending hours a day in a mirror, had my own journey for sure with food and body. And so I decided, okay, for my clinicals, I'll do eating disorders. It was a great choice. It's been a good fit for me. And so eating disorders, and specifically eating disorders at the residential level of care, is most of what I've known for my career, my early career. But I was quickly doing my work and a little bit dissatisfied, mostly psychiatrically, with the amount of co-occurring serious challenges these young kids I was seeing. And I was dissatisfied with clinical outcomes. Around the same time, in graduate school, and I think this was good, I think this was providential, I also started to struggle a little bit with my own mental health. I had anxiousness that I couldn't explain. Like, I had never struggled really with my mental health before. Tro knows this part, and I always feel like embarrassed. And this is not cool. It's not cool to talk about your mom, but I always end up talking about my mom. My mom went to medical school and just sort of is like interested in metabolic health my whole life, basically. I think since high school, I've said, like, I grew up in a low carb house, but when my anxiety was suddenly bad, she introduced me to Georgia Eat and said, like, I want you to follow this research and I want you to really think about what's happening here. She kind of tends to turn my head in a mechanistic direction. If you're a therapist, you're trained on a biopsychosocial model, but what I really find is that the bio is disregarded, and maybe for good reason, right? We're not docs, we're not MDs, but what I find in my field is that we focus a lot on the psychosocial, right? There's a lot of conversation about, well, the reason this is happening is because dad works X amount of hours, right? These sort of psychosocial factors, but we spend less time paying close attention to the mechanistic factors and the biology. But my mom had that influence on me. So that's how I did Dr. Ead's training, and just more and more hungry for this like amazing burgeoning metabolic psychiatry space. And yes, I'm now considered somewhat controversial because I believe that a specific dietary change really can be beneficial. There's a lot of reasons why that's highly complex in an eating disorder population, as you might imagine, but the fact remains that it's a pretty amazing intervention, and I think it can tell us a lot about how the brain and body influence and interact with each other.
My brain is going at a mile a minute right now, and I think this idea, right? And you said it's controversial, so let's talk to the listener about the controversy. Historically, in the space of restricting eating, right, which is the eating disorder space, maybe there's intense poor body image, really terrible relationship to weight and weight stigma. There's these intense societal pressures to look a certain way and be a certain way, and those can play on the anxieties that we all may have. I've been very vocal about my own anorexia as a kid and binge eating throughout my life, and a lot of it plays from this. But the idea of then using a dietary approach is quite controversial because this group historically has restricted certain foods. So I think that's a big issue in this space, even though, I mean, just think about it, right? It makes so much common sense. The brain needs nutrients, and really the removal of poison, right? Everyday poison that we accept, right, as food, right? It needs the removal and everyday poison that we accept as food, and it needs nutrition. So to us, all the people in this room, and I know Brian's like nodding his head and you're nodding your head, you know, how do we get these people the nutrition they need while fundamentally telling them to restrict something that modern world considers food, which probably isn't food? So that's the controversy. So I'm wondering, you know, as you've sort of explored professionally in this space and sort of dealt with, you know, various people in this practice, how open are they to this idea of a metabolic health intervention or a ketogenic diet? Or do you find that there's significant bias? Do you find that you have to hold back sort of like what mom gave you, this curiosity, this focus on root cause and health? And, you know, do you find you have to hold that part back?
Yeah, I have so many thoughts. Like I tell parents, I run a parent support group. And part of what I say to parents in the group is like, if you've met one child with an eating disorder, you've seen one eating disorder. Like, we know an eating disorder really is a combination of symptoms that occur similarly in a group of people. But that really, just because the symptoms are the same, right? The urge to restrict food is consistent amongst these folks. It doesn't really tell us a lot about what's happening for that person specifically. Tro, you spoke about in your case, there was desire for thinness, right? There was desire to be in a small body, and that's highly consistent. But even that actually doesn't necessarily occur in every person I see. So a little on that end, like, where I am now is, if I've met one person and I've seen one pattern of eating, I've seen one pattern of eating. And like, that's really where I go. I have adult clients who have been at this for some time, who now come in and say to me something to the effect of, what I really know I do best on is meat and vegetables, right? And then we work a little bit on like, why might that be, right? And the addictive processes of the food and for that person, right? And we sort of go from there. But by the way, there are little kids I work with, and I don't know what you guys think of this. Like, I think, so the whole conversation about nuance, so much nuance all the time. I work with little kids who, they're very afraid of an Oreo cookie. They're deathly afraid of an Oreo cookie. They're deathly afraid of a piece of pizza. For an 11-year-old kid, I have concerns about that, right? Now, there may be some conversation to be had about what is then the intervention for that child. But if you can think about it, what I like to do a little bit in eating disorders now is like try to extrapolate eating disorder interventions out to other things we know as therapists. If we were a therapist who works primarily with phobias, you can't have phobia of Oreo cookie. In fact, the only way to let a phobia of Oreo cookie go is to hold the cookie, bite the cookie, experience, right? So there, for some kids, I think I do think like, you can't be afraid, right? We can have a conversation about more or less optimal foods. And then, by the way, I have clients for whom there is no real reason for them to consume that ever again. So I don't know. I don't know what you guys think about me saying that. I don't know if you,
Yeah, it's very
I don't know
nuanced.
if you
I think
think it's controversial that I think that, but
no, I think it's important. I think I think that's a really important discussion because, you know, why are you for me, I think, okay, why are you afraid of that Oreo cookie? Is it because mom's 300 pounds and has diabetes?
yeah,
Why,
yeah,
well, what's
yeah.
the underlying, did mom tell you over and over and over it's going to kill you, if you eat a cookie? That, and so many people, and it's important because a lot of my patients, they're doing great, and then they go and have cookies, and they go like, I don't even want to look at you, doctor. I'm so embarrassed. You're not gonna like me because I had a cookie. I'm like, okay, you're a human. You're a human being, and so yeah, I would love to hear your nuances on that because I think it's a really important topic. Because some people, I'm telling you, I see it the same way. People are keto, they go, oh no, I would never have a strawberry. Are you kidding me? How many carbs are in a strawberry? And then that like their whole life is afraid of strawberries. Or in
Um,
Tro's case, fruit. He said thinks all fruit is poison. That's what I heard, but I don't know. But that's what I heard.
You know, I think you hit the nail on the head. What is the etiology? If you ask my kids, they go to Saturday school or Sunday school and they have pizza. I don't restrict it. I tell them where this food sort of should be in the place of their diet. And sometimes you can't escape on modern food. So if you're living in fear of modern food, that's I mean, it's everywhere. You'd be afraid all the time. And I don't think fear is a good motivator, right? Imagine living in fear your whole life, avoiding food because of fear. And what a great world it would be if we could turn that around and say, there's no need to fear it, but you choose for the large part food that makes you feel good or that is good for you because you deserve health. Now that's a huge frame shift. I think you're absolutely right with like anxiety, fear of, God, I'm deathly afraid of heights. What do? I go rock climbing and I expose myself. Should I take somebody and I do exposure therapy, right? And now I'm not afraid of heights, you know? So I think, if you're fear motivated, maybe you consider exposure therapy, right? But I think pretending that the Oreo is healthy and part of a balanced meal, or needing to include it for the sake of inclusion,
yeah,
I think that's a dangerous place to be, which is, I feel like that's where most of modern eating disorder management is.
yeah,
It's like you should include it, you shouldn't fear an Oreo.
yeah, yeah.
Well, start by not fearing steak and eggs, then go to Oreo. Like do Oreo last, you know, maybe after you do the steaks, eggs, and fish first.
The eating disorder world is also, as you may or may not know, is very siloed, right? So it's I am the therapist. I'm not the RD, and there's almost always an RD on my team, and I defer to my RD, right, on most food decisions. This is the normal paradigm, right? This is the typical paradigm. But in my case, like for me, I'll say to my clients, I'll say to their families, like, okay, what are we having? And I'll ask for some food recall in the last couple of days, and it's like some egg whites, some chicken breast, a waffle. And so like part of my mission is even just like, where's the fat? Like so many families I work with are just like habitually, they think that, they think they're offering their kids sort of a nice balanced options, but like chronically under fat, which has all kinds of problems for the brain anyway. But
Yeah, let's step back for a second, like with anorexia from a physiologic, and gosh, I'm blanking on the doctor's name, but he's a doctor from Germany who's doing a lot with anorexia. And I was looking at, and what's that?
Guido Frank?
Yeah, Dr. Frank. Yeah, Dr. Frank. I just saw him give a talk, and I was like, wow, it's kind of, his data is kind of interesting. And so the common history of with anorexia or binge eating disorder, where they're saying, look, don't restrict any food category because then they're going to binge on that food. Right. So as a matter of fact, I had a run-in one time. I mean, I was the victim on this one, but I had a patient with fatty liver disease, pre-diabetes, like all these health problems from binge eating disorder. And so the patient asked me, in your opinion, what's the best thing I can do? I said, the best thing you do is cut carbohydrates as much as possible because carbohydrates was causing the fatty liver disease. And we went through the physiology and explained it. The next day I got it like pulled out of an exam room. They go, someone's on the phone and she's cussing and wants to talk to you right now. And it was her nutritionist. And she goes, how dare you? You're telling her to restrict a food group. Are you kidding me? No, no, no. You're a doctor. And I'm like holding the phone, like I didn't even introduce myself or talk to her. But it was this huge emotional response. And so I said, okay, so should I tell my alcoholics to drink alcohol in moderation so that they don't binge on alcohol? And then she hung up on me. But the point I was making was like, look, when you have an acute medical problem going on, that we have to fix that problem. And the best way is to let the patient understand. But I understand restrictions, not like, but if we can cut back, can we moderate? What can we do in that situation?
Yeah. Like, I mean, just to talk about state of play a little bit, like, I don't know the people, like it is, it's considered controversial that I believe in food addiction as an eating disorders professional, right? Like, so now I say I work across the eating disorder spectrum, lots of which ends up being more of a food addictions paradigm. And it's considered controversial that I even believe, right, that could be a condition, but there's no question. It totally replicates other substance use disorders. And I happen to think, as a clinician, for us to disregard the reality of using food as substance, you're exactly right, Brian. Like it would be, we would not otherwise enable people who come see us like, oh yeah, just keep just cocaine in moderation, just like we would not, especially if people have a real reaction to that substance.
In your experience with eating disorders, what percentage, I know it's kind of hard to say, but is actually true food addiction, right? So I see a lot of patients in my practice. I go, this isn't really like, they're not really addicted. That's lifestyle. They go, I'm just used to, going to happy hour every night with my friends. And I don't like if they, are on vacation, they don't do that. And so how much of it is like lifestyle and how much is like, and does it develop into a food addiction with time if you keep doing those kind of behaviors, right? If you every time you get stressed, you eat a cookie, whatever it is.
Yeah, I mean, Vera Tarman has like great perspective on all of this. I think, and I'm over-indexed too. Like I'm not a good sample because by the time they come to me, if they could have been right, like so a client who comes to me and says, I know what I really do well on is mostly meat and veg, maybe some fruit, maybe some berries, right? By the time they come to me, if they can't adhere to that, right, there's really something else going on. So I don't have a good perspective, right? Because I would say like, something I think is interesting is the diagnostic criteria. Tro, I've heard you talk about this a little bit. Something I think is interesting is the diagnostic criteria for binge eating is about, it has this like nebulous language, like, more than what someone would consider to be normal in a set amount of time, right? And so then usually what I say to my clients is like, okay, so that doesn't mean a big dinner. That means like not just a dinner, but several dinners in 1 hour setting, right? Then I have to explain what that criteria means. And I really try to nail down with my clients who come to me for binging, are we binging? Or does our behavior more similarly look like cigarette smoking, like continuous use? Is it more like continuous grazing all day long? And I end up seeing a lot more of the latter, the more continuous use behavior than like a bag of apples and a bag of cheese sticks and true binge.
Ryan, I think, has seen true binge when we were on the cruise for the low carb cruise, and he'll see that probably again next year. It's funny. I want to hear your definition. If maybe you're closer to this material than we are, can you let the user, the listener, know, what makes you alerted to, let's say, binge eating, right? What are the signs that tip you off? What are the signs that tip you off to somebody who's maybe a harmful user? What's the signs that somebody maybe is food addicted? If you can sort of just educate us on who those people are, and then how you would, maybe go about using, diagnostic tools, or what you would do to explore, if your suspicions are confirmed.
So I keep an eye on that like continuous use paradigm, right? Like, is it actually like you have a bad day at work, you have a fight with your spouse, and then it's one episode of binging, or is it right? Like I look for the pattern of behavior. From a diagnostic tools perspective, if you're coming to me and you're really struggling with food in some legitimate way, if there's been recent considerable weight gain, then I will, in most cases, administer a YFAS, a Yale Food Addiction Scale. They have it amended for kids. And that can be a really good tool. So that's what I keep an eye out for. Yeah. Lots of weight gain lots of weight gain recent, or like 100 pounds in a year, or like that, right? These kinds of patterns, or is it more like, since I was 12, I put on XYZ year over calendar year, right? Those kinds of differences.
The biggest sign for me, because you're right, some of these diagnostic tools can be a little nebulous, like like that most people would consider to be large. I think ultimately for me, what I'm looking for is there social, economical, health, or psychological distress?
Yeah.
Right? Are
Yeah.
you spending a lot of money on food? Right? Are you spending a lot of, is it weighing on you emotionally? Is the guilt and the shame like just weighing on you? Are you avoiding social scenarios because of food? Are your relationships suffering because you're like running out of the home to go to the gas station to pick up some chocolate, right? You're leaving your kids behind. I mean, these are all things I've heard, by the way. Those are like the things that I'm attuned to. And, interestingly, in my clinic, I think you're right. I'm over-indexed. It's nearly universal. Are you seeing that, in your clinic? Like, I find, if they've made their way to me, this is probably something that's going on. Now, I have some people who just don't like the fact that they do it, right? They're eating pizza and they don't like the fact that they're doing it, right? And there's no sort of emotional distress. And if you tell them, hey, maybe you should cut your pizza out, they're like, oh, gosh, you're right. Like, there's no defensiveness or stubbornness or opposition. It's just like, yeah, I do want to quit drinking. I have been smoking a little bit too much. I should get rid of it before it's a problem. I've been having 1 or 2 drinks every week and I probably should cut it out. This sort of emotional processing supports their goal. Whereas, if you see that emotional processing antithesis to their goal, like they want to stop eating pizza, and the minute you're like, hey, maybe we should, do something else instead of, in between meals going and getting pizza, if there's that defensiveness or, so I'm always like paying attention to these.
There's huge
subtle,
perceptions. There's huge, like when you say something like, hey, can we cut back on pizza or bread? And someone starts crying. That's a huge emotional connection. I'm not telling you to give up your dog or cat, right? There's a huge emotional connection. And when some people are afraid of being hungry. So if you go, we don't want you to be hungry for the first month, all right? As long as we can cut out these processed food and sugars, let's just work on nutrition right now and not worry about weight loss. Let's not worry about that at all, right? And so people can grab onto that. At least they're not going to worry about, oh, if I don't eat the pizza, I'm going to be starving all night and I'll be miserable, right? This fear of missing a meal or a snack it's real.
Yeah.
So what sets you off? Like, this is a problem, or, what are those little clues that you've, learned along the way? The unspoken words of addiction or binge eating, or, I know we all know it. And I see you nodding your head. Nobody can listen on the podcast, but you're like nodding your head. Yes, yes,
Yeah.
yes. What are those things that have made you sort of attuned to it?
Well, like I think I've heard you talk about this a little bit, Tro. Like one of the problems with the way like there's conflict between the food addiction space, metabolic health space, and the eating disorder space. I think I've heard you talk about this is like the professionals within, like they also hold closely to the content because of their own experience, right? So you were someone, Tro, who was highly restrictive as a kid, but also struggled with some binging and then came to some food peace through an intervention that you recommend to your patients now, right? And there are clinicians in the eating disorder space who will say, I came to my peace through an all foods fit approach. one of the challenges is that the clinicians are really close to the content, right? So it's almost like, I'm not an MD, I'm a therapist. So it's actually rare to me when I meet someone who's like non-emotional about food. I'm like, wait, you don't take this personally? That I'm right. Like when I meet someone who can be somewhat neutral about food, it's actually shocking to me. By the way, that replicates my own experience. I probably have an emotional relationship with food. And it also just is the nature of my work. So yeah, if you're holding really closely, exactly like you guys said, if there's real emotional resistance to cutting or removing foods of any kind, and also maybe if there's real emotional resistance to reintroducing certain foods, right? There's real emotional resistance to reintroducing steak for a lot of people. Meat aversion is a real thing. Yeah, secrecy, obviously, secrecy is a tell for me. If you're doing, and certain times a day is a tell for me too. Nighttime eating is a tell. Another tell, I don't know if this is what you're getting at, Tro, is cars. If you've got a thing about your car and your food and the eating in your car and the buying and the drive-through and the car, it's a thing, cars. I also don't know if this is what you're getting at, but if you are linking familial or spousal expectation about your health to eating. So if you do this kind of rebellious or revenge eating, then we're really in a hard place, right? So if your spouse or your family member or your mom or your dad says, I hope you can stick to it this time, and that makes you want to reach for the Nutella, then we're really in an interesting place emotionally.
Yeah, and this brings up what Coach Jessica was talking about. That's why it really impacted me, is talking about these strongholds. Like, you could do it for a week, but then you blow it, or your parents have told you, or your husband, or whoever it is, and then like you're saying, it's like, are you eating more? What are you doing? Like that nagging thing, right? And people like do worse, and it doesn't work clearly. So like, I mean, and there's so many different approaches, but we can see what triggers that person, right? If someone tells you not to eat and you go, that's it, I'm eating 2 bags now, right? You had too much to drink. I'm going to drink 4 more drinks then, It's tough because there's a lot of like what's underlying that: anger, resentment, like rebelliousness, whatever it is.
And
And you hurt yourself in the process.
Yeah, yeah. And like, the thing about food as substance is it goes so undetected for so long, right? Like it really is socially acceptable. People want to talk about how socially acceptable alcohol is, certainly. Alcoholism is not socially acceptable, right? I don't know if that's a generational thing, but more and more of my peers are sober by choice, right? Not even really because something, it's just I find it's more and more a common thing, but food sober, like you can be using food as substance for a really long time, decades and decades before someone's able to language, to you about it.
And what we see too, Tro, I mean, well, sorry, I'll shut up after this, Tro, but what we see too is we have people that have been 400, 400 pounds, 380 pounds, and no one says a word about their eating. And then they start losing weight and everyone's like, oh my gosh, you're not eating pizza anymore. You're not eating this. And then they could become concerned when their health is benefiting.
I don't know what to say. I love the way you put that, Katherine, like the tells, those subtle little tells, those subtle little clues that like open your mind and say, wait, there's more here than meets the eye. And everything Brian just said, like there's something else, and I think what you said also is very insightful. And Brian, you hinted at it, which is it can be a substance use disorder, right? It cannot be. I mean, but how many people, if you look in your own life right now, Brian, I'm curious if you can answer this question, Catherine, you too. How many people use food solely for nutrition? Like solely to nourish their body, and that's it. How many people do you know?
Nobody. I really don't know anyone who just goes, I'm just kidding, because let me look at, I mean, most people want to have pleasure from their meal. There's something about connecting with people, social, right? Like we all know, like we look at the literature and you go, okay, you're trying to lose weight. Yeah, eat early in the day and skip dinner, right? But socially, hard to do, hard to put in practice and go, okay, I'm not going to eat dinner with my family. I'm going to sit there and watch them eat because I eat at 4 o'clock instead of 6:30 or 7, right? So there's a lot of that where we kind of go there. We have certain social issues. I have a lady just lost 23 pounds by switching her dinner to earlier and not snacking after dinner. That's it. That's all she did. That was her thing, because nighttime eating was her issue. So she made that switch and she's like doing great. One switch, one thing. It took her a while to figure out. But she says now my husband comes and meets me at work. We eat our dinner together and hang out, and then I work for another couple hours and come home. We go for a walk with the dog. Right? She's figured it out.
Yeah, it's interesting. Like, I'm thinking about it on this call. I'm a woman, but I have a colleague in Greenwich. He's just like really, he's an MD, but he's like a great, like, super, he's a throwback, right? He does home visits and all these things, and he thinks really evolutionarily. And the first time I met him, he was like, no, we're totally different. Right. He made this major delineation between the fact that I am a female and he is a male. And he said, like, he really emphasized to me, like, you will think considerably more about the home and nourishing your family and all of these things, right? Like, he was like, you will by design be over-indexed on these things. And I think it's totally true. Like, my understanding of food and what it does for you is probably a little bit more than fuel. It really probably is. It probably is more about entertaining and connection and taking care and all these things. Like, I think it's yeah, it would be hard for me to be like actually totally neutral about it.
Well, so that's what so the minute we go from this is more than nutrition, right? We're talking about a substance use or a potentiator of some process, whether it's enhancing the feel-good hormones from socializing, whether it's, a substance in and of itself that we're abusing, right? I think like this idea of looking at obesity particularly and looking at food addiction as a substance use disorder is like, I think it's spot on. I think that's exactly the way I would look at it. But then I wonder, like, do you think that these, we talked about food addiction and we've talked about anorexia. How much do you think there's like cross harm, where you have like these people who are food addicted and maybe you're telling them to restrict, and then you have people with anorexia and you're telling them to include. Do you think these messages collide? Do you think, I feel like the modern eating disorder space, people look at these as collisions, that they're completely irreconcilable. But how do you deal with both of these populations? You've dealt with eating disorders. Now you're really dealing with a lot of food addiction and food relationship issues. I know you've talked about wanting to help people who are on sort of GLP-1 medications also.
Yeah.
How do you reconcile this all and to help, how do you reconcile it,
I am motivated by the biology because I think that it separates the wheat from the chaff. Like, I just think that if you can, like Ashley Garrett, right, at Yale Food Addiction Scale, right, at Michigan, like her lab, some of what they focus on, and really like some of the most compelling food addictions research to me is just some things like brain scans, right? Just like looking at some of these processes and saying like, this is what's happening. And guess what? Over time, as you reduce addictive food substances, the brain really does heal itself. It actually really is a healing process, physically and literally, to reduce the consumption of some of this stuff. And I think that if we can point more and more to those, like, right, like not theoretical ideas, not nebulous language about emotions and thoughts and feelings and social constructs, but really like just look at this brain scan, really just do, and one of the biggest challenges, and this is a lot of Guido Frank's work, is Guido Frank and what's her name? Tro, researcher in the UK.
Agnes Aiden,
yeah. Like we're just a little bit limited theoretically on like the way I started this, right? It's not consistent. Why would someone starve themselves? It doesn't make any sense. And I actually think the field is a little bit limited on understanding mechanistically how that comes to be. We don't really have good mechanistic answers. And so I think that is a major stumbling block right now. I think that's a major stumbling block. The more we can understand what's happening from a mechanistic perspective, I think the paradigm will shift, and then these two will become more reconcilable. And I think it will just become more about like most optimal foods for brain and body, and it will become a little more simple in that way. But right now we live in this it's got to be all foods fit all the time approach.
How do you manage like concomitant anxiety, concomitant depression? How do you approach, your mental health counselor? I'm sure you've seen it all, personality disorders. To what degree do these play into, how you manage food relationship?
Well, yeah, like probably I wouldn't have. I mean, my mom was like into metabolic health, and I was sort of like, yeah, I get it, right? Like, mom's about steak and eggs. And if I wasn't seeing the serious co-occurring, I probably wouldn't have been drawn in this way. I'm in a metabolic psychiatry working group with Nicole Laurent and some other psychologists. And the papers that we're working on in that group, they're not eating disorder papers even necessarily, right? They're all diagnoses, but it is I think there are some secrets of the eating disorder world. One of the secrets is that like people are just metabolically compromised on both ends of the spectrum, right? When you think about eating disorders work, you think of emaciated people. That's really not what we see. We see both ends of the spectrum. And then the other truth of the eating disorder world is that the co-occurring is the consistent. Like I see anxiety and I see depression in almost every person I see with an eating disorder. It's so rare that you would come and the only symptoms you would have are food and body related. There's almost always some considerable depression, anxiety, personality disorder, in some cases, in some cases bipolar or other co-occurring. We see it in almost every case. ADHD for sure with kids, for sure ADHD.
And OCD and all these other
OCD,
type of conditions and type A personality type and all this. And so, that's one thing. Dr. Frank's stuff that's why it intrigued me, because I've always thought this. I thought, if you're anorexic, like we'll take it to a less extreme example, like Jason Fung's talking about all the time. Just yesterday, I met a guy. We were talking. He goes, "Oh, I did a 3-day fast. Oh my gosh, my energy, my focus, my calmness, I felt so good." And so if you're anorexic and you're coming in with a bunch of stress, anxiety, social pressures, and all these kind of things, and you get into that ketotic state, you feel better.
Yes.
And then you start eating terrible foods, and then boom, you come out of that and you feel like garbage. You go, okay, I'm not going to do that anymore. I'm going to keep right. And so for me, I always thought anorexia is you don't have the same, like you see yourself different in the mirror, right? Your body image is different, like your skin and bones, but you think you're overweight still. But I don't know how much is that and how much is the anxiety, stress, depression, all this stuff that gets better in this state of ketosis.
100%. Yeah. And make no mistake, like I meet kids who come, the eating disorder world gets up in arms about ketogenic diet or any of these things. I think they're really well intentioned, because make no mistake, we do meet kids all the time who come in and say, well, my mom and dad are keto and now I have a couple celery sticks for breakfast, right? It really can't, kids can get sort of sideways on this stuff. I hear it all the time. So I understand why, your patient, Brian, whoever that clinician was who was upset with you on the phone, like I understand why people are sensitive about it, because we see it. But again, yeah, like I think as we come to understand things better mechanistically, like about what is it about reducing calories that has a calming effect, or what is it about restricting some macronutrient groups that has a calming effect, and how do you do that in a way that allows people to live their best life, as it were.
Live their and I think that's a huge thing. That's what Tro and I were seeing, and that's what was so amazing. That was surprising to us, because we weren't even, I know at least I wasn't, but Tro might not have too, but we weren't looking out trying to treat diabetes and go, we got to get your sugars under control. And then we get their sugars under control and they go, I'm not as hungry and I feel pretty good and I don't feel like drinking and I'm exercising more and I'm getting along with people and I'm less stressed. And all these things are happening. And like people go, like one of my patients that was on Fat Fiction said, I walked out of a fog. I was in a fog my entire life. Now I'm laughing and I hear the bird singing and I want to engage with people. And I was never like that because she was metabolically sick her entire life. So when we said this, it was such a it was such a weird thing. It's like you have the magic pill. Like as an example, I just wrote down because I just saw a new patient. She came in and her husband dragged her in, and he's a military guy, super loving, good guy, but she's had schizophrenia with multiple hospitalizations, major depressive disorder, polycystic ovarian disease, diabetes. You go through the whole list. All these are metabolic diseases. And I go, oh, it's the same treatment. We could get, and you're drinking 5 sodas a day. How if we intervene with that? What can we do? What can we substitute? And she was crying because she had hope. She's like, I just thought I was gonna be like this the rest of my life, and no hope. And we're like, okay, listen to what Jules has to say, and these different people with metabolic mind, and how powerful this is from a just looking at that, not even looking. They're not even looking from a diabetes, obesity time frame, right? We're looking from pure mental health benefits.
Yeah, well, I do get to a place where I'm like, the symptoms psychiatrically are really bad, and it's because the lithium is not working, and and as the insulin resistance worsens, so too will all of the other symptoms we're seeing. And it really is like, I think we're catching up. I think the space is emerging. So grateful for Metabolic Mind. But in the interim, I'm on the phone with psychiatrists saying insulin resistance in the body is insulin resistance in the brain. Because
Do they buy it? Do they buy into what you're saying?
I don't think they think I know what I'm talking about. And by the way, maybe I don't. Right? Like maybe I don't. It's not my job necessarily to understand a little. But I don't think I also
don't give them credit. I got to be honest. It's ignorant. I've gone up and down the research. They don't know.
They don't know.
The reverse is true. We know the reverse is true, and I'm sorry you got me my anger stoked, but we know the reverse is true, meaning drugs that cause, that we use in psychiatric issues worsen insulin resistance. So we know sort of the reverse is true. We know that every deficiency known B12 deficiency.
I don't think people know that. Like what you just said, I don't think people know that, or they've forgotten at some point.
Well, they kind of know, but they can't put it all together. They need somebody like Chris Palmer to show them how this all fits.
Well, yeah, and Tro, and that's true too. It caused the insulin resistance in the weekend, but the issue too is like I just interviewed Andrew Kutnick this morning. He's a type 1 diabetic, great guy, and he goes, okay, look at the symptoms of hyperglycemia, major depression, anxiety, stress, and all these things are hyperglycemia causing it. You fix the hyperglycememia, all these things get better. And then people say you're crazy. It has nothing to do with it. I'm like, well, it's very clear. Look at the symptoms of all these things.
Actually, we have data better. We have interventional data. Real food diet has been shown, real food diet has been shown to improve depression in both adults and adolescents. Real food diet has been shown to decrease anxiety symptoms in both adults, and this is interventional trials that have been shown to do this. We have retrospective data on ketogenic diets, cohort studies showing that it improves depression. Excuse me. And so we have a lot of data now. I mean, it's not, and certainly exercise. I think that's the other picture. All of these things, mental health, pertaining to mental health, anxiety, depression, can improve with exercise. But to come back to what you said, a little bit earlier, Brian, which is, yes, I think most doctors are missing it completely. They don't understand the drugs that they're using. Simple drugs like Singulair can worsen mental health. Simple drugs like, SSRIs GLP-1s that can have effects on mental health. Look, all these drugs can, antipsychotics can worsen insulin resistance. They just don't know the interplay between what they're prescribing, what they're doing. But coming back to the first point, just like 2 seconds ago, I was trying to get in this comment because we were discussing, the evolutionary sort of basis, the biologic basis, talking about the brain scans, in anorexia and in eating disorders. I think bottom line is most docs don't understand any of this, right? All they understand is here's a medication, like try an SSRI, right? They don't understand how anxiety can worsen weight gain or weight loss. They don't understand how depression can worsen weight gain and weight loss. They just kind of know. So I'm imagining from Catherine's perspective, being frustrated, talking to these docs, out there who are sort of working with your clients, and they don't get it, and you're kind of in this position, and you're taking that position here on the podcast of like, maybe it's not my place. It's absolutely your place. It's
But your
absolutely
place
your
is whether it's going to go on empty deaf ears or not, right? Because I have doctors, cardiologists, I'm like, here's the data, here's the study, look at this study, look at this study, and they go, yeah, I still don't believe that. Okay, I don't like your research. I just want to believe what I want to believe, right?
Yeah.
It's
Yeah.
hard. It's a hard situation for sure.
you know
So
it
what's happening,
absolutely
Katherine,
is.
clinically? What are you seeing clinically? Are you seeing improvements in your patients doing what you're doing?
Yeah. Yeah. No question. I think as I go on, like this is where I have to fall back on nuance because for some people it's very clear, right? For some people it's very clear to stay food sober, as it were, right, is the right intervention for them, and they're off to the races, and we can sort of do some really good work within there. On the other hand, like I haven't, right? Like for all of my more restrictive eating disorder cases, I'm still doing, I don't like, I'm doing more of an inclusive diet, right? All macronutrient groups, that kind of a thing. A more balanced diet, right? Whole foods are optimal, all the things. But really the advice I give actually to restrictive clients I have is feed your child like your grandmother would have fed her family. Like that's usually what I fall back on. Right? So just like all the things, super simple, whole real food, real butter, real dairy. That's what we're doing out here. But then for someone who really meets food addiction criteria and can be receptive to that idea of food as substance, and then you sort of don't eat the trigger foods, that's really clear. Where it gets trickier clinically is something more like the studies Guido Frank is doing, where you intentionally try to do create ketones for someone with anorexia and see the results of the ketones in the anorexic brain. I think it's fascinating. I think you want to do it in a really controlled setting because the fat phobia, meaning dietary fat phobia, and meat aversion is a real thing. I mean, like I literally do steak exposure with people. Like we eat a steak together. So I just think, right. And I do meet people who come in and say, well, ketogenic diet is celery sticks, right? Like, so there's just like a lot of ways that things can go off the rails. So I think you just want to be really in a really a lot of guidance, a lot of careful, like just, by the way, making sure people get enough food. And that's true on both sides of the spectrum. I have clients who really got a lot of weight on, and I ask them week over week, are you getting enough food? I'll direct them to your guys' courses. I'll direct them to Tro's course, and I'll say like, what does Tro say? And they're like, I can't be hungry. And I'm like, you cannot be hungry, Clinically, the other good thing I see, and I'll say in defense of some MDs, is if you are a pediatrician, now the pediatricians see up until 26, right? They see a lot of different kinds of young people. I think pediatricians are disturbed. Their training still empowers them to be disturbed and concerned about metabolic health. And if anybody in the eating disorder space is pushing back a little bit on the all foods fit for all people narrative, I actually think it is some MDs, and I'm really happy to see it because some of the docs I work with, and these are just like, they see all kinds of kids and people. They're just looking at everything, and they're a little bit removed from the eating disorder treatment world dogma, and it's a good thing because to them, like, it's just not adding up. We just can't allow people to be, we think we're treating their binge eating disorder by having all foods, but in the interim, we're leaving them with really serious medical complications, not the least of which is fatty liver, which we see a lot. We see it a lot.
Yeah, we're seeing a lot in kids.
Yeah.
Yeah, it's a nightmare. So, yeah, I think I like your approach. Say, look, let's not be overly restrictive. Let's try, and then over time, maybe you say, okay, you're still gaining weight or whatever. Let's try tweaking this down a little bit, tweaking this up a little bit, and making That's what Tro and I do too. We go, let's make little changes here and there. Be like, see what we can do, what's working, and pull this lever. Maybe you shouldn't be eating butter 6 times a day, right? Like, and making, just changing these things. Like, what are your goals and what's happening? Are you hungry all the time? But people just keep doing what they're doing, and they never say, oh, maybe I don't need to eat, And that lady too, she was having like 6 cups of coffee during the day with cream in it. She got rid of that too, and then she eats earlier, and she's great.
What, I'm just curious, one last couple questions here. What are the types of patients that you like to see? Do you like dealing with food addiction? Do you like dealing with eating disorder? Do you like dealing with binge eating? Where's your wheelhouse? I know we had Tori from our practice who became a mental health counselor. She loves dealing with anxiety, depression, ADHD. Where do you find your interest sort of leading your practice to? And certainly we want to shout out to your new practice that you have out in Fairfield, Connecticut. And we'll include the links on how people could sort of find you. But, what's the type of patients that you really like to work with?
For anorexia patients, if a child, if a young person, young adult, really has a restrictive eating disorder, bulimia nervosa or anorexia nervosa, one of the ways I'm really enjoying working right now is a family-based treatment model. What I really love about it is it empowers parents, which I'm really about. Like, I'm really not about heavy-handedness from medical providers. I really think like parents got to be able to advocate for their kids and make the right decisions. What's great about FBT is assuming it's a fit for that kid. They can stay in the home. And by the way, then parents can have really like a lot of control, a lot of decision making about what the quality of food their child is getting. Do you know Caroline Beckwith?
Well, I know her, but I know her name,
She had anorexia, and her aunt is the other author on Guido Frank's most recent paper. And so as a family,
that's right. Yeah. Okay. Yeah, I do know her. Yes.
As a family, they decided that the way to cure her anorexia, cure that psychiatric distress she was continuing to have, was through a ketogenic diet. But what her mom writes about in the book is like, if you're doing family-based treatment, no one is going to talk to you about food quality, and you got to watch food quality. So that's what I really like about family-based treatment, because it gives families a lot of power about quality of food, keeping their child in the home, all of those things. And Anorexia is a great resource, and they're doing some of this stuff. And the Beckwiths and Barbara Skolnick, they're awesome. And then the other thing I like to do is, I like to do food addiction. And I like to do people who are receptive to the addictions model. If you can understand your food stuff as food as substance, then really like we can do some great work together. And I'm not like most clinicians, I'm not really picky about what it looks like. What matters to me is that you want your life to be different. You want your life to be better.
Yeah, and all these things are so important. I was just thinking, like, while you're talking, I don't know why. I was thinking about somehow I got on mice, and I was thinking about these mice were picking cocaine water over, sugar water over cocaine water, and you say it's not addictive. And it's like, okay. And they were already addicted on cocaine before the study, and then they picked the sugar water still. And so to say there's no food addiction, it's just, I think at this point, like I said way back 7 years ago, Troy, I think it's malpractice on your side to not consider it. Right? Like, why would a 450-pound diabetic be craving sugar all the time?
Yeah.
Doesn't make sense. It's not for survival because your 450 is not high enough.
Yeah. Yeah.
Yeah, it's detrimental. At that point, it's, and that's one of the questions in most of the surveys out there, are you eating despite ill health or physical pain? So if it hurts to walk and you're still eating the same way, okay.
Well, you'd use despite adverse consequences. Yeah.
Yeah. And that's straight from the addiction playbook. I think looking at obesity from the addiction model or harmful use model is probably the best way to look at it. Is somebody, just a harmful user, right? Maybe they don't need a very aggressive, approach. Are they, like really, is there emotional and psychological distress? Maybe they need some more help from Katherine or, practices, and if they're, modifying their behavior, like the sneak eating and the avoiding things, eating in their car, hiding wrappers, etc. If you're at that point, you need help. Like, you need to call Katherine, you need to call Brian, you need to call myself. You need help, right? And there's nothing embarrassing about needing help. Gosh, like all of us here have talked about, You know, you mentioned Catherine being an emotional eater. I've talked about my own food addiction and binge eating, and certainly Brian, you've talked about your own struggles. So there's no need for shame, and in fact, shame is probably part of the addiction cycle, which took me years to understand. Shame and guilt is like pathognomonic for I actually need help.
Mm-hmm.
You know, that's how you should interpret it. If you're experiencing shame and guilt, you should then follow that up immediately by saying, I don't deserve the shame and guilt. I don't deserve to feel bad, and I need help, and I need to get help.
And if you feel like you're weak and you have no self-control, I have no willpower, that's just the way I am, that's a cop out. It's stuff, it's lies what we believe, these strongholds that we talk about. And I think so much of this hour has been so informative, so powerful. Actually, Tro, you start out with this story, and it was way different than I thought it was going to be, like a funny story. But to hear that they're saying, look, there's no hope for you, let's just end your life. And you go, man. And after that, I was thinking, so do we go next to the morbidly obese people and say, look, you can't stop your eating, so let's just kill you, right? You're just laying in bed. You're not contributing to society anymore. You take up more space. And so this is such a dangerous area, because that's saying we have no hope for you getting better. Now, if you have Lou Gehrig's disease and ALS and it's chronic progressive and there's nothing you can do and nothing's worked, you go, okay, I can kind of understand what you're saying. But when you say, gosh, these are clearly what Catherine's doing, you can treat these conditions, you can help these people, rather than just saying, life's not worth living anymore. It's like, well, as a society, what do we value anymore? It's just mind blowing to me that we'd even talk about this and consider it.
And I know you guys talk about this all the time. Like, I like it when clinicians and families are dissatisfied with outcomes as they exist. Like, if you are dissatisfied with treatment outcomes as they are at present, you are right to be dissatisfied. They're not great. And some of the best things I hear, and it is coming down the pike, is parents will say to me, hey, I had a friend who told me their kid got on a ketogenic diet and they're a totally different kid. Are you hearing this? Right.
Mm-hmm.
You have mentioned, Catherine, you have mentioned this to me before. Is this what you're seeing? Right. And I think as parents can rebel, parents, clinicians can say, like, the status quo is not good enough, right? Good enough will not be good enough. Then we're on a good path.
That's
Awesome.
wisdom.
How do people find you?
My website is Well Supported Behavioral. I'm at Katherine Tague most places. I'm not super active on social. That's probably something I should think about, but that's where you can find me. www.wellsupportedbehavioral.com.
We'll put the links to that.
And can you work, do you work via Zoom, or are they local people that you're working with, or can you work with anyone?
Yeah, I work via Zoom. If you're in the tri-state area, I would love for you to come see me in person. I think it's beneficial, but telehealth is the future.
Tri-state, just so everybody knows, New York, New Jersey, Connecticut. All right, because there's a lot of tri-states, but yes.
You can edit that.
Karen, thanks so much for joining us. This is really important. I'm excited about the work you're doing. And when we come back and talk again, you're going to say, oh, now we have studies saying this is true, right? And so it's awesome. Or we change tact. If it's not working, we do something different. But I think being open-minded, like you said on the outset, that's really critical.
Thank you, guys.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.